So first of all, we have the ACE inhibitors, so the angiotensin converting enzyme inhibitors. You may already have heard about these drugs. They are very frequently used for the management of hypertension. Essentially, we know that one of the hormones that is most responsible for increasing blood pressure is angiotensin, and particularly angiotensin type 2. The kidney is going to produce angiotensin type 1. So our body first produces angiotensin type 1 or angiotensinogen and then angiotensin type 1. And then a very special enzyme that we have in our blood vessels and other organs called angiotensin converting enzyme or ACE is going to transform angiotensin type 1 in angiotensin type 2 and thus increase blood pressure. So ACE inhibitors are going to basically block this enzyme and they are going to prevent this transformation, preventing that increase in blood pressure. So ACE inhibitors are very old drugs but very used because they are very effective and very safe. You may know them as captopril, enalapril, lisinopril and ramipril. These are all generic names. As you may remember, we use always the generic name in this channel. The indication that is mainly used for these drugs is hypertension. However, we now know that they protect the kidney in patients with diabetes and other forms of kidney damage, and they decrease cardiovascular risk in these patients. So they are going to have a better blood pressure control, they are going to have a decrease in kidney damage, and they are also going to, since they help us control hypertension, they are going to decrease their risk of mainly patients with diabetes, but also patients with hypertension, to have further along their lives a heart attack. However, they also have some adverse events. So patients that take these drugs may find they have cough. This cough is sometimes very difficult to manage since the ACE enzyme is also responsible to destroy some other things that cause cough. They can leave a bad taste in a patient's mouth, and sometimes, once again, this lasts for a long time. They can cause potassium and calcium to be not in the right level, so potassium may increase and calcium decrease in a patient's blood. And this is especially important since we are in this video talking about patients that already have some kidney damage, so they have another reason to have these electrolyte disturbances. They might have a rash. They might have hypotension, especially if we combine them with other drugs that may be affecting our blood flow, and they may present edema. Now, besides these common adverse events, these are one of the three groups that we are going to talk about today that may cause, in the beginning of administration, kidney damage. So these drugs, despite the fact that they are very good for the kidneys and in the long term they protect from kidney damage, in the short term, we may find that since the kidney of that patient is already used to the current environment, even if it's a toxic environment, when we change that environment, we may cause the kidney to suffer in the beginning. So we may have to monitorize in those patients creatinine clearance and other parameters to determine that the kidney is responding correctly. And once again, as time goes by, the kidney is going to really thank the adding of these type of drugs if the patient is a candidate to the current drugs the patient is already taking for diabetes, and once again, in some cases, even other diseases that can affect the kidney. What are the effects on the kidney? They are going to, as I said, decrease the kidney damage. This is mainly shown in several meta-analyses. Many of these meta-analyses for these drugs are very old because the effect or the preventive effect on the kidneys of these drugs is really old. So we have known for a long while that these drugs protect the kidney in these patients. And these patients will have a halted progression from microalbuminuria to macroalbuminuria. This is one of the main parameters we use to determine that the kidney of a patient with diabetes is suffering and is going to have chronic kidney disease. So the halting in this progression is really essential for this protective mechanism. Of course, we are also going to find that it decreases blood pressure. High blood pressure is also going to destroy the blood vessels of the kidney. So this is a second mechanism of protection. They cause renal vasodilation because angiotensin 2, since it increases blood pressure, it also causes renal vasoconstriction. So less blood reaches the kidney. When we give these drugs, more blood is going to reach the kidney, and that is a good thing. Thus improving renal perfusion, so more blood reaching the kidney. However, these drugs, since they are very old, they don't have much newer studies. they haven't shown in clinical trials, these big trials with a lot of patients, a decrease in patient mortality. We assume that it has that effect, but we don't have the clinical trials to back it up. The second type of drugs is the ARB2, so angiotensin II receptor blocker. As you may imagine, or as you already know, these are like close cousins to the ACE inhibitors group of medicines. We once again have angiotensin I, it transforms into angiotensin II. This is going to then couple with the receptor in all of the blood vessels and other organs in our body. So basically what these ARB2 drugs do is they block this angiotensin type 2. So angiotensin type 2 is synthesized, we do find it in our bloodstream, however it can't do its effect because it's like a cork that we put on angiotensin type 2. And since we're not inhibiting the ACE enzyme, we don't have things like cough, and the risk of edema and rash are also greatly decreased because, once again, the inhibition of this enzyme was one of the factors that caused cough and edema in the ACE inhibitor. Some frequent examples are losartan, candesertan, valsartan, and telmisartan. They are also mainly used for the management of hypertension. They also leave a bad taste in our mouth. They increase potassium and decrease calcium. They have the risk of rash, but it's much lower than ACE inhibitors. They do cause hypotension and they do cause edema. Once again, rash and edema are really decreased from ACE inhibitors, but they may also cause it. They also have this double-edged sword effect of, in the very beginning, in some patients, causing a decrease in kidney function, but in the long run, of course, they are also a very good drug to protect patients from kidney damage in diabetes. They also decrease cardiovascular risk, just as any other hypertension medicine. And thus, we have that very positive effect besides the nephroprotective effect that they also present. They decrease just the same as ACE inhibitors. They decrease progression from micro to macroalbuminuria. They also control blood pressure, renal vasodilation, improve renal perfusion, and they also don't have shown benefit in mortality, since they are also much or very old drugs and very secure, very safe, and very effective. But nonetheless, I leave some meta-analysis so you can check out this information. The third group, the SGLT inhibitors, so inhibitors of the sodium glucose cotransporter type 2. This is going to be a drug that works, of course, inside of the kidney. When we take a look at the kidney is going to basically decide from all the things that reach its glomerulus what is going to stay in the blood, because it's very important to the function of our bodies, and what is going to get eliminated through urine. This is or should be all of the toxic things, all of the wasteful things that our body already produced. And the glomerulus is usually very good to determine what is going to stay in the blood and what is going to get eliminated through urine. Just taking a look at three main elements. We have, for example, glucose. Glucose is almost always going to be asked to stay in the blood. Even if some glucose goes to the path of elimination, then we are going to have specialized cells that recapture that glucose and puts it back into our bloodstream. We're going to have creatine. This is going to be a toxic product or a waste product, not toxic, but a waste product. So this is always going to go through urine to be eliminated. And finally, water. Water is going to depend what is the hydric status of our body. So we may want to maintain most of the water in our bloodstream if we're dehydrated. If we drank a lot of water, then we're going to want it to go through the urine to maintain an adequate balance. And thus, the kidney can adapt to recapture more water or eliminate more water. And when this process has occurred, we say that the blood is clean, so it has only the things that we wanted it to stay. This is called clearance. And the body is capable of clearing like 90 milliliters per minute of clean blood in a normal process. Once again, this is a very intricate process, very complex process, but it's essential for our well-being and our life. One of these enzymes that participates in blood clearance is, of course, the one responsible of glucose. Since glucose is such a valuable thing for our body, it's the main energetic coin that we use, we're going to have that when glucose escapes into urine, we're going to have these proteins, SGLT1 and 2. These are going to grab glucose, they are going to push it to our bloodstream. So we don't eliminate any glucose in our body, since glucose is considered so important for our well-being and our physiology. As you may, of course, be guessing, this, of course, ensures that almost all of the glucose that goes into the urine goes back into our bloodstream. A normal patient should not have any traces of glucose in its urine. Of course, some patients with diabetes may have such high levels of glucose that this mechanism of SGLT1 and 2 are overcame, and then we might find some glucose in urine. Of course, as you may guess, this bridging effect is caused by these SGLT2 proteins, and these drugs are going to basically block this SGLT. So all of the glucose that goes into the bloodstream and even more is going to get eliminated through our urine, since we are assuming that patient has very high levels of glucose and we can safely eliminate it through the urine without having other consequences in the health of that patient. This reduces glucose once again in our bloodstream and increases it in our urine. The three main examples, these are relatively new drugs. There are canagliflozin, dapagliflozin, and empagliflozin. They are used mainly for glucose management, so they are going to be given to patients with diabetes for the management of the diabetes. But now we know that they decrease renal and heart damage in heart failure, so they are going to be really, really good drugs in patients with diabetes and a lot of their comorbidities. They are, however, not exempt of having some adverse events, so we may find urinary and genital infections. We have very large numbers of glucose now in our urine and in our genitals. This tends to cause or make it simpler for an infection to appear. Patients have polyuria, so they pee a lot. Very frequently, they may experience back pain, dehydration, because that glucose they are eliminating through the urine. It's, of course, also pulling water, so the patient should drink a lot more water. If that doesn't happen, then the patient might find with a dehydration, and they may experience hypoglycemia. This is especially true if these patients are also given something else to manage their diabetes. This doesn't mean that these drugs cannot be combined with other anti-diabetic drugs. However, we should also always be wary and prevent these hypoglycemias. And these ones are the third double-edged bladed swords, because once again, in the short term, they may induce some kidney damage, but in the long term, they are really nephroprotective. They protect the kidneys, especially of patients with diabetes and even other diseases. What's the effect on the kidneys? Here we have much newer studies, because once again, these are new studies, new drugs, They decrease kidney damage independent of albuminuria, so we might find even in very, very early signs of kidney damage that these drugs protect those kidneys. They decrease glucose hyperfiltration. This is something normal for a patient with diabetes, since they have a lot of glucose. They force the kidneys to overwork. So this is going to decrease with these types of drugs, because once again, they have lower levels of glucose. They decrease the loss of renal function. They decrease death, the risk of death in these patients, and cardiovascular events. They also, of course, are very good for glucose control. So high levels of glucose are directly toxic for our kidneys. If we have better glucose management, we have a better kidney health. There are, once again, a lot of studies. This is a relatively new meta-analysis. And of course, it shows the great effect and the great protective effect that we see with the use of these drugs in our patients with diabetes and a risk of kidney damage. And finally, once again, very new drugs, analogs of glucagon like peptide 1 or GLP-1. These are going to be drugs that mimic the effect of one of the main helpers of insulin, called incretins. So GLP-1 are going to help insulin, and they're going to fight against some of the hormones that in respect fight against insulin. In our body, of course, we already reviewed that when we talked about diabetes in general, and I'm going to leave a video explaining further up here. But we have two groups of drugs. We have insulin and all of its helpers, where we can find glucagon-like peptide and incretin, and we have contrarregulatory hormones of insulin. These are going to prevent insulin from doing its job. Basically, with what GLP-1 drugs do, they are going to tip the scale to favor insulin activity. Some of the examples: dulaglutide, liraglutide, and semaglutide. They are also very, very used for control of glucose and weight. They are one of the best drugs we have right now, one of the best therapies that help with weight management. In fact, semaglutide was in the news and was in social media recently because of the famous Ozempic and Wegovy. Because of the large effects that they had, they become very popular drugs, and then patients with diabetes that needed, of course, even more, couldn't find it in the pharmacy because everyone was trying to buy it. It of course helps with weight management. It helps with glucose control because that is the main function and the original purpose of these drugs, and thus they protect the kidney. We might find that patients that start these drugs have stomach aches, anorexia. Of course, these two mechanisms also favor the weight loss, hypoglycemia, and pancreatitis. So we have, these are drugs that do have some adverse events. They are pretty safe and they are pretty effective. And of course, now we know one of the most recent studies, the study flow of semaglutide, has just shown that they directly affect the kidney, reducing oxidative stress and reducing intraglomerular pressure, thus protecting the kidney. However, this is not an effect shared by all of the group. The drugs I previously mentioned are the ones, the GLP-1 analogs, that have this effect. Other drugs like exenatide do not show so far that effect. Finally, some key points. One, you should use the highest tolerated dose by the patient. So if the patient tolerates a higher dose, we should increase the dose because the higher doses offer the greatest protection for the kidney. This is, of course, talking in the context of protecting the kidney of that patient. However, as we mentioned, every patient is different, every patient has different needs and different risks, and every patient should have a professional consultation. You shouldn't combine ACE inhibitors and ARB2 because they essentially work the same and you don't get any additional benefits. You just increase the risk of an adverse event. You should start when microalbuminuria, defined as 30 milligrams of albumin in 24 hours urine, or low glomerular filtration rate, so the kidney is not working as fast cleaning our blood, especially when we have less than 60 milliliters per minute of clearance, are detected. If you start in these very early stages of kidney damage, the health of that kidney is going to last much, much longer. Finally, as I said, not all GLP-1 are nephroprotectors, just the liraglutide, dulaglutide, and semaglutide so far. Maybe future studies will find some others, but right now these are the main ones with a shown effect on kidney protection. Finally, these are the references where I obtained this information. I hope you can check them out. Very important information to protect the kidneys of our patients being treated for diabetes, and very important to prevent this epidemic of chronic kidney disease that we are seeing in a lot of countries in the world, most of it due to diabetes. So very, very important information. Thanks for watching, and as always, help us change the world. Share the information.